Consultant in Emergency Medicine, Associate Medical Director for Clinical Quality and Improvement from the University Hospitals of Leicester NHS Trust. First of all, we just have a few simple housekeeping points. The session is being recorded, and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of the presentation, there will be the opportunity to ask questions. If you have a question, please use the raise your hand option in the panel on the right-hand side of the screen. Alternatively, you can write your question in the questions section on the panel. During the Q&A sections, we will unmute you to ask your question in person. Thank you, and I'll now hand you over to Dr. Banerjee. Okay, over to you.
Thank you, Paula, and good afternoon, everybody. I think this is really exciting to talk about the Silver Book, which is something very close to our heart. But what I was really going to do is, instead of spending too much time talking, is try and keep it as brief as possible so we actually have more time for discussing subsequently, especially around the implementation of work streams for improving older people's care. So the Silver Book project, we worked on this between, I'm trying to remember, I think it was February 2011, and then it was published in June 2012, although I started the work around September 2010 when I was invited to start setting up the team and discussing terms of reference and what we were going to do. So that setup phase took about 6 months. So it's kind of interesting to see that 3.5 years has gone by, and the stuff that we did is definitely still very contemporary, although there are other issues that I'll bring up that we would need to think about as well, which we didn't particularly address in the Silver Book at that time. So firstly, I think in some ways we really think about the wheel of life and this whole kind of cycle that goes around. And in some ways it is quite nice to be old, because that means we did not fall victim or prey to other conditions that can take our life and kill us earlier on. But of course, there are changes, as we know, to our physiology and to our social circumstances that come with the process of aging, which obviously makes some of us a bit more dependent on other situations and prone to suffering the consequences of being vulnerable. But well, that is life, and it doesn't matter what we think about it. Again, the advantage of getting old, of course, is that we are living to a ripe old age, but it also means that the world is getting grayer. So if you look at some of those figures, older people will outnumber children by 2018. By 2038, over 65s will constitute 1.3 billion, increase of 7% of the world's population currently, to 14%. Europe is the world's oldest continent, with 23 of the world's 25 countries. In the UK, what we are certainly seeing is that patients over the age of 70 are accounting for more than 15% of attendances in urgent emergency care, representing about 40% of the admissions. But the biggest growth, obviously, as we know, has been in the 85 plus, and we also know that most patients are being admitted to hospital via the emergency department. So I will be speaking a little bit about the emergency department, mainly because of the interface position of the department, and also partly because I happen to work in one of these. So it doesn't matter what we think about it, they're already here. So the American Psychiatry Association several years ago described this phenomenon as a silver tsunami. And I certainly know quite a few of my colleagues have got very serious reservations about use of that term, simply because when we talk of a tsunami, we describe something which is sudden and comes out of the blue, whereas this increase in the number of older people is not something that is coming out of the blue and was entirely predictable, and we knew this very well 10, 15 years ago. When I first started work on these issues about 10 years ago, it was very obvious to me even at that time that this was going to be a big problem. So in some ways, I think we could have done a lot more in the last 5 to 10 years, which might not have quite brought us to our knees in the way it has, especially with regards to emergency care. But we are where we are. So the question is, what can we do from here to improve care for older people? So I think a lot of the time people don't realize that it's not so much the volume attending emergency care where the main problems with regards to this, what the services face, happens. It's actually in the admission times. So we know, for example, typically between 65 to 70% of all bed days are taken up in the National Health Service hospitals with older people. We also know a huge proportion of this population above the age of 65 has got dementia and or delirium at any one time being admitted to the hospital, and we also know there's a huge increase in the number of people who develop delirium while they've been admitted to hospital. There's lots of other publications showing how the different kinds of harm that happen to older people in the system. And if you were to look at your safety data in your organization, and you look at falls and pressure ulcers and VTE and COTI and other HAIs, you will find that the majority of times the people who suffer the consequences of the faults in the system, the errors in system delivery, are actually the old. So that's a really good angle to approach the whole thing from, is that even if we are not particularly passionate about caring for older people, but we are still interested in changing our safety matrix and the way we perform as a healthcare system, focusing on older people is good, because that will help us improve even our safety data and make us better performing systems. What we have seen from several reports over the last few years is that there is definitely a system-wide issue about the way we care for older people. And that has been repeatedly seen in many of the CQC reports, and of course going back to the Health Service Ombudsman's report when it first came out a few years ago, and how even down the years, a lot of these things are continuing to happen. And I think it's really important that at no stage we start looking at this as problems due to individuals behaving in unprofessional manners. Be under no illusion, these are problems at a systems level. People behave the way they do because the system is designed to support them in behaving the way they do. So I think it's really important we start looking at the problem as a systems problem and completely move away from trying to apportion individuals as culpable for shortcomings in care. It is about defining better process, and through that describing better accountability. So when the Silver Book work was started, one of the things we definitely wanted to do was actually, first of all, demonstrate through our membership that improving systems and improving quality of care for older people was not something that could be done by a doctor or a nurse or a physio. It needed a bunch of people coming from different backgrounds, and it also needed a bunch of people working across different service settings. And the problem was not about trying to decode the issues at the service level, but the problem was really trying to understand the problems that affect the patient in their journey through a siloed health system where there is no strategic alignment of services with regards to how we measure and deliver quality. As a result of this, there were huge variations in practice across the system, and there were massive transitions in care, which were also causing harm to the patients. And what was we knew this already, was that there were pockets of great practice in lots of parts of the country which were not necessarily being shared or identified across the patch. And what we definitely wanted to do with this document is start changing practice, and through changing practice, influence subsequent policy development. We all know that having policy that supports the frontline staff in doing the right thing is really what improves outcome in patients. But in some ways, it's a chicken and egg, and we really need to start demonstrating innovative, high-quality practice that can influence subsequent policy modification by showing how it has affected older people's care. What we were also very clearly asked to do, this was by Matthew Cook, David Oliver, and Alistair Burns, who were the three entities at the time, that it was only over the first 24 hours of an urgent care episode. However, it cut across service settings. So it started with an older person in crisis seeking help from the system, and the system responding, and the response could only be delivered in a care home, or could only be in a primary care setting, or could only be in the emergency department, or could actually travel or move across the entire system in different settings. But we really wanted to look at all of these settings to look at identifying all of the things that are on that it says in the book. As you know, it had a pretty wide membership, which definitely represents the breadth of what we felt were a very essential group of people for majority of the times. What is obviously missing in here are the surgeons, and particularly orthopedic surgeons. But we know that through the National Falls work and the National Hip Fracture Database, through subsequent work that was actually kind of happening at the same time, the Royal College of Anaesthetists was running a separate group on perioperative care of older people. I was on that group as well, so we referred to the work from that group as well. So we kind of had those angles covered. The College of Pharmacy were involved, even though they were not at the table as authors. They were involved as stakeholders. And what you can't see is that over a period of about 6 months, we had extensive feedback from lots of professional organizations who gave us regular feedback on what to do and how to take this piece of work forward. And the College of Pharmacy were one of the extremely influential ones in terms of helping us look at a lot of things and correct those errors. So we had some really excellent membership for authorship as well as membership in terms of stakeholder feedback. So the work was led jointly by the College of Emergency Medicine and the British Geriatrics Society, and it just so happened that Simon and I were both working in Leicester, and Simon was he was honorary secretary of the BGS, and we led this piece of work, and we had worked in Leicester for several years before that, so in some ways it was very easy to do this work, working with people we knew. We also became very, very close to the whole group and still maintain contacts with a lot of them through different ways, least of all through the AFN as well currently. So the purpose was we wanted to describe the issues relating to older people accessing care in the first 24 hours. And then what we were very keen to do was describe the competencies that the system needed to provide in order to respond. This was a very far cry from trying to describe the number of physios, OTs, geriatricians, and nurses that were required, because we were very much in agreement that local models of delivery had to be decided based on resources, structures, and access to people. There is absolutely no point describing a system that starts by saying you need so many geriatricians or you need so many physiotherapists to actually deliver this particular package. It was very much around, no, this is the kind of assessment, this is needed.
Hello, apologies, we seem to have lost Dr. Banerjee. He seemed to be, I could hear him okay. If you'd just like to bear with me a couple of minutes, I'll see if I can try and get hold of him. Okay, if you just bear with me and I'll see what I can do. Hello, apologies again for the technical issue. I've just spoken to Dr. Banerjee and he's going to try and log back into the system again, and then hopefully we'll be able to hear him as clear as we could a few moments ago. So I'm really sorry for this issue, and if you could just bear with us again. Thank you very much.
Okay, good. So can you see the screen as well?
Yes.
Fine. Okay, so going back to the purpose, what we really wanted to do was describe the issues around older people accessing care in the first 24 hours. You can see the rest of it. One of the problems we had was we did not have prems and proms at the time for capturing some of those measures, so they're not mentioned in the document. The other thing that I would like to emphasize is the whole thing about the kind of
we really wanted to bring up the issue about competency. So we wanted to make it very clear that it wasn't about putting in so many geriatricians, so many nurses, so many physios, but it was about looking at the pathway, understanding what needed to be delivered, and then describing, okay, so what are the competencies needed in the workforce to deliver these elements of the care in this particular setting, and then decide locally as to what was the best way of allowing those competencies to be present based on access to the processes, the resources, and the staff. And that is the reason why we have never mentioned the kind of workforce, although it's very obvious that the workforce needs to be diverse to represent the different needs of the patient. So the document is really a best practice guidance, and although we actually had a look at whatever literature and whatever evidence there was available, we all know that comprehensive geriatric assessment and delivery of CTA is the most evidence-based intervention that there is in older people, which is a fantastic NNT as well, and that is what we really wanted to describe. We, as you will have noticed, it doesn't have anything on commissioning and the mode of delivery of competencies, because those needed to be decided at a local level. And what we also wanted to describe is that actually where the care was being delivered, again, depended on local service configuration. So there was nothing about this has to be done in the emergency room or this has to be done in the acute medical unit. There is no evidence to say that actually that changes outcome. What there is evidence for is what is being done that changes outcome, which is essentially comprehensive geriatric assessment. It's just that some areas have already tested and trialed delivery of CGA in some settings, which shows that it works, and it may not have been trialed or demonstrated its effectiveness in other settings, but there's nothing to believe that it would be any less inferior in any other setting, provided the practicalities of delivering it were addressed. The underpinning principles are very much around understanding that we had to build a system that actually had respect for the autonomy and dignity of the older person. So give you a simple example, the kind of problems that we face on a regular basis. Not long ago, I had somebody in the 90s, and I had 3 generations of women in the room. So I had the grandmother there who had been readmitted to the hospital 7 days after being discharged, and an extremely irate daughter and granddaughter basically asking as to why she had been sent home inappropriately when it was totally unsafe for her, and why she had not been, why we hadn't ensured that she actually had carers to come and look after her. Now, this lady had no cognitive impairment. She was absolutely fine, sat down on the trolley, and I said, well, have we asked her as to what she wants? And I said, well, what was it about? Did you not want any carers? She said, no, I don't want anybody entering my house. I said, well, what about the fact that we sent you back home and your family clearly think it was not the right thing to do? She said, I have no desire of staying in the hospital. I want to be at home. And it was quite obvious to her family that at the end of the day, the whole question about is this safe or is this unsafe or is this right or is this not right has to be decided in conjunction with the person for whom the care is intended. We cannot have prescriptive, paternalistic, condescending care systems that basically tell an older person what needs to be done. It has to be arrived in conjunction with the person and respecting their autonomy to make the decision, even if it may seem not necessarily right to the care provider. If somebody is fully aware about what they're doing, irrespective of their age, they should be given the freedom to do that. What is our job to try and make it safer for them without impinging on their autonomy. And that is the reason why the fact that every older person has got an equal right to health and social care assessment, just like anybody else, is absolutely there, and we should not have an age-defined restriction to service. Personally, I'm certainly very much against having any kind of policy which says, oh, this is closed to people of the age of 85. I mean, that is frankly ageist, and we cannot be having those kind of things. It's just not fair, and it's just not proper. Not to mention from perspective of healthcare provision, it's very silly, because if we were a business, we would never shun our biggest customer group. So why would we want to do that in healthcare? It's just the wrong approach. It doesn't make sense. think about understanding the whole systems approach is crucially important, because we are very good at trying to set our own house in order. And the way I kind of tend to look at it with my systems thinking hat on, actually your house cannot be in order if you live in a dirty neighborhood. So work with your neighbors to get your neighborhood in order. So just trying to make sure that my ED is trying to do what is needed is not going to change necessarily the patient's outcome if their care needs span the entire interface, and if their care needs are going to continue over a period of time. My job is really to understand what proportion and what element of those care needs could be addressed most effectively in the emergency department for that particular person, and then liaise and have those relationships with other providers to make that contribution to this person's care. So a little bit about CGA. This is a wonderful stuff that I copied of the BGS website that Finbar had put in some time ago, and it's absolutely fantastic. It gives you a really good idea about what needs to be done. Of course, the next step for me is to develop an app so we can have this for non-geriatricians on their iPhone, and they can just tick on it and start doing a CGA. That would be the day. It would make life a lot easier, I'm sure. A little bit about frailty syndromes. Even though the document says older people, what we were very much aware of was actually the main focus was really around frail older people. This was less about the 90-year-old playing golf and more about the 70-year-old in a care home attending with recurrent falls. And as you can see, the document kind of hints towards that. So we have put in just little boxes and things to kind of support that kind of approach. I referred to this earlier on, but this is really to get people to understand where we sit. A person in crisis who's above the age of 75 or 85, passes through the system. And what is it we can do at different parts of the system to ensure we provide more proactive care closer to home, which is really what most of the people would want. Despite whatever we put in, we have to bear in mind is that there will be many people whose needs will be so much that the service would have exceeded its capacity to deliver those needs, and the person would need to be passed on to an area of higher intensity management to have some of those needs addressed, provided it was appropriate to do so. And therefore, at every step of the way, what is it we can do that would actually make the process efficient, get rid of redundancies, get rid of duplication, but with a very clear emphasis on trying to do the right thing. Recently I heard this wonderful statement, which is providing the right care for the person is evidence-based medicine. Providing the care to the right person at the right time in the right place is evidence-based management. I thought that was fantastic. So in some ways, it's kind of trying to understand how do we couple evidence-based medicine with evidence-based management to really provide the best outcomes. And the key always has to be around outcomes. What is it we're trying to deliver here? Because we have to remember everything that is described in all of these are processes. Most of these processes would impact on outcomes, but we need to be very careful about defining those outcomes and measuring them when we're setting up the processes. We did put in some whole system matrix. These are absolutely at a service level, and they are woefully inadequate compared to what we are really trying to address here. And hopefully we are, there's already quite a lot of work going on in terms of patient-reported experience measures in older people, which John Young's intermediate care audit has made use of. And there's, of course, other pieces of work going on with regards to understanding PROMs a little bit better, so we can have a better way of understanding the patient and the staff angle of care delivery. We did put in some standards which kind of, which we felt were, as a multidisciplinary group, we felt was actually important. And some of these obviously hit some controversial notes. For example, primary care response within 30 minutes was something that didn't go down very well. At the time, I remember there were some letters in Pulse, but again, it doesn't say a GP needs to see a patient within 30 minutes. It says a primary care response, and it doesn't say you have to go and see the person either. It could be a telephone, triage. It doesn't have to be a doctor. So it could be a care navigator. I think the key thing here is basically to emphasize somebody responding within a period of time that was consistent with the kind of subsequent behavior we see, because when this response doesn't happen, typically it's the 999 that responds, and a lot of these patients in Land are coming to the emergency department a lot of the time inappropriately. So presence of frailty syndrome should trigger a more detailed CGA, and this should really start within 2 hours, either in the community patient's own home or as an inpatient, according to the patient's needs. Health and social care commissioning should really be contributing to early assessments. And of course, we really wanted to make this thing about self-harm, and you will subsequently see there's quite a lot on elder abuse in the document, because this is something we are missing on a fairly regular basis. There are some generic recommendations which span the entire settings, and I'm not going to go into any of the details, but they're there in the document for you to look at. And the same thing is true for the generic competencies we also described. Operationalizing best practice. So these were basically looking at the different kinds of services that are already being used in different parts of the world to actually improve outcomes in older people, and we have basically referred to the kind of multidisciplinary teams that were found to be useful, and some very specific thing about the emergency department, obviously, because this is where a lot of the older people are coming through, and what we really wanted people to think about was how to build a model that would support delivery of early CGA. So in Leicester, obviously, we have our own unit attached to the ED called the Emergency Frailty Unit where this thing happens, but there are different ways of doing it. But the key thing was really to provide the right care as early as possible. And of course, designing the kind of place which is conducive to better care is also useful. There is good evidence for this now. There was a health building note published on creating dementia-friendly spaces from the Department of Health sometime in late autumn last year, and that does give very good guidance on what to think about when you're designing new spaces or refurbishing older ones for improving outcomes in older people. So this is very much the kind of model that is used in Leicester. We've got the football team again, very much influenced by a lot of work that has happened in different parts of the country, and we have tried to look at what is it that we can deliver with the resources we have, and we've tried to. This is what we've been trying to do over the last few years. So one other thing, so this was a very specific piece of work we did in Leicester. This is building our new emergency department and the emergency care center. So all the acute care units are coming down to the front row of the hospital, and we have basically set up a design team, and we have come out with incorporating design elements that improve outcomes in older people. So we are using the HBN as well, along with quite a lot of work that has been done by health architecture researchers in this area. So the way I look at it, if it is good for a frail older person, it's going to be good for everybody. We also have a geriatric emergency medicine fellowship here, which has been going on for 5 years now, just about to advertise for year 6. And this is really to develop champions in the emergency department. So although it started off with a focus on emergency medicine trainees, last year I had the first couple of geriatric trainees doing the fellowship. Obviously, we slightly altered the program, but what we are trying to do here is basically develop leadership for improving the quality of care in older people. So coming from a geriatric background, but understanding more of acute care principles as well as care in the emergency department, I certainly see a role for people like these to be working in emergency departments alongside emergency medicine people trained in geriatrics, very much like the pediatric model has evolved over the years to really improve care for older people. We've got a couple of other stuff we have got here which are going to make a difference. So one is we are in the process of getting the details. So this is kind of in there with organizations helping us. Institute of Health for older people, very much a local initiative to help with translational research and quality improvement activities for older people. We also have a patient safety unit, and again we have got quality improvement projects relevant to care for older people that we are also delivering through the unit. So to kind of like look at the main things, one of the things about the Silver Book is to kind of deliver a service that that is a frailty-friendly front door. So if you're talking about the hospital, this would probably be the front door, including an emergency department. If you're talking about the community, this is probably going to be a virtual front door with a multidisciplinary team who would be coming out to provide care for the patient closer to their home. We needed integrated care systems, but we also needed to understand the population need in order to deliver individual needs and commission the right kind of services as well as the right kind of model. There is definite need to bring in improvement capability into the whole thing to support the processes. So some related links that you may want to have a look at. So this piece of work that is happening with www.ichom.org, which is basically developing a outcome indicator data set for older people. So the outcome indicator data set for older people is the work group I'm leading, but there is a separate work group on outcome indicator data set for people with dementia. Alistair Burns is leading that, and that is going to come out. Both will be out in the next few months, and it will help us understand the commissioning a little bit better in terms of measuring the effect of what we are trying to do. There's the European Union task force that Simon and I have been involved with, developing a curriculum and research priorities as an integrated stream of geriatricians and emergency medicine doctors across Europe, and that should be quite useful as well. And just we have also got an emergency geriatric international kind of consortium looking at the problems faced by emergency care systems in other countries. Well, currently it's Singapore, Australia, USA, Canada, and the UK, and we're really trying to learn from each other. We've got very good relationships and good networks in understanding what works and what doesn't work from failures and successes in other places. So it's all around creating a movement around older people's care, and the Silver book has certainly been a great use to us as well. So we've got the Silver ED, which is being planned, and of course we have launched a Silver Appeal charity to raise more money for it. So we're really trying to get people to come into this, what is more like a movement to improve care for older people. I'll stop there and allow time for questions.
Okay, thank you, Dr. Banerjee. If you want to leave your last slide up on the screen, and then people have got your contact details if they need to email in more questions. Like Dr. Banerjee said, we've got time for some questions now. If you'd like to ask a question, you could either raise your hand. You can use the raise your hand option in the panel on the right hand side of the screen, or you can write a question in the question section panel, and then I can read it out for you. If you raise your hand, I can always unmute you to actually ask your question. Okay, so we just give everybody a couple of minutes to do that, because I know sometimes it takes a little while. Okay, looks like we've got a question from Lorna Gibson, so I'll just unmute you, Lorna. Hello, Lorna, can you hear us? Hello, Lorna, you got a question, please? No, I can't hear anything from Lorna. I've unmuted her, but I can't seem to hear anything. Looks like Sharon Greenman has got her hand up. If I unmute you, Sharon. Hello, Sharon. Can you hear us? Nope, I can't hear Sharon either. Like I say, just give everybody a few minutes to type in a question if they've got one.
Yeah, I think typing might be
takes a little while
option at this time. Yeah.
Oh, looks like we have got a question. Oh, it's from Lorna Gibson. She said, sorry, yep. She's on the phone, but she can't see the slides. The question she'd like to ask is about how this influenced commissioning arrangements.
So there, as I said, there isn't a section in the Silver Book on commissioning. It was more on recommendations, best practice in terms of getting what we needed to do and how to understand and deliver those needs. In terms of how to actually commission the relevant services, we haven't got anything in it. This will be something that we are actually exploring separately through the ICHOM work currently, and there is a session coming up soon for the end of February, beginning of March. So the older people's data set with iCHOM has been funded by NHS England, and NHS England are running a commissioning workshop to talk about how to commission this data set. So I'm sure if you look out for that, when that is done, I can easily send it to the AFN network, and you can maybe attend that if somebody wants to.
Okay, Lorna's popped a message on saying thank you very much for that answer, Dr. Banerjee. Just waiting to see if we've got any more questions. There's no more hands up at the moment. Right, at the moment. Okay. Oh, looks like we've got a question now from Sharon Greenman. So, her question is, Dr. Banerjee, would you be able to go to their ED department to speak to their staff?
Yes, absolutely. I mean, I think a huge part of the work that we have done is actually about engaging with staff. So when we first set up the emergency frailty unit in Leicester, you know, I mean, it wasn't an instant success. There weren't a lot of nurses jumping up and down to come to work in that, because most emergency department doctors and nurses, you know, are much more interested in stuff like trauma and immediate, you know, stuff which in all fairness kind of gives you an immediate feedback when you're doing it, kind of, you know, MIs and strokes and stuff like that, particularly trauma. So older people's care is kind of like a bit unsexy and kind of slightly boring. So it took us time to get there, but over the years we actually have a very dedicated stream of ED nurses who in fact have stopped working in the main department because they constantly work in the emergency frailty unit, and they absolutely love it. So currently we've got 8-bedded unit, but from hopefully March 2017 we're going to have a 16-bedded emergency frailty unit, and one of the key things has been overcoming some of the initial concerns that people had within the emergency department as well as within geriatrics, because the unit is very much a jointly delivered unit. And, you know, some of the geriatricians were not going to come down to the ED, full stop, not over the dead body. And it was, again, getting them to start feeling more comfortable in terms of interacting with my colleagues, and getting my colleagues to start feeling more comfortable in having a geriatrician hovering around. And now if you were to come and see that, you wouldn't believe what we went through in the first few years. But it takes time to change culture. So it has to come from within. You know, I'm more than happy to go and talk to people, but the real work has to happen with the people who are already in these organizations to start changing the culture.
Okay, that's lovely. Thank you very much, Dr. Banerjee. Thank you for your question, Sharon. Sharon's actually replied saying, thank you, I agree we need some assistance with engagement. I can email you to arrange.
Absolutely, no problem.
Okay, we've got another question from Bev Wills. Question is, what level of support was provided in Leicester ED to enable CGA in 2 hours and champions of older people's care?
So not in the ED, that's why we have got the emergency frailty unit. So we move patients out of the ED into the emergency frailty unit to start doing that. But in terms of teams, we have got primary care coordinator, physios, OTs, and geriatricians who provide in-reach from the emergency frailty unit into the emergency department. We have got forms and tick boxes that aid the process as well. But most of the time, we don't start it within 2 hours, no way. Most of the time, we can't even get to see most patients within 2 hours. We are so completely crowded. And, you know, it has been like this for the last 6 to 9 months. And I suspect our emergency department is not exactly unique in that. And most departments in the country are facing these kind of issues. But again, every time we see these issues and we look at the whole problems across the system, it becomes much more obvious that we are not doing the right things across every component of the system. And that is why we are paying the price for it in terms of poor care and crowding. So we have the EFU, and we actually move people out of the ED into the EFU for this process to happen. It needs a nicer, kinder environment, which is less loud and less intense. And we find it works a lot better. It will be different in the new department because that will have a capacity about 4 times what we currently have. Our capacity is for about 110,000, whereas we see 150,000. So we are quite crowded most of the time.
Okay, Bev has replied saying thank you for that, Dr. Banerjee. Okay, it doesn't look like we've got any more questions at the moment. Dr. Banerjee's obviously got his contact details on his slide there if you'd like to email him. Oh, another question has just popped up. Oh, actually a couple.
Yep.
The first one is from Emma Neal. How do you transfer information between professionals on the pathway to inform the CGA? For example, information gathered by ambulance crews, community matrons.
So the ambulance crew, we have got paper copies of their information. So currently, most of our ambulance crews bring electronic records, which are then printed out in the ED, and with the community matrons, the primary care coordinators who work in the department, they have got separate pro formas which they use. And then for the whole CTA pack in the emergency reality unit, Simon had devised a full clerking pro forma in which the whole thing is done. So we have got loads of forms and pieces of paper in which to do this. Come next year when the new department opens, we're going to be paperless, and that will be the opportunity for us to build in the CGA process electronically, such that it could be done with an iPad, and we could actually kick off at least with some of the headings to help us do it more effectively. And I mean, it's a very cumbersome system the way it is in terms of gathering all the information. But having the primary care coordinators makes a massive difference, because not only will they not come and talk to the GP, they will talk to the district nurses, they will speak to the families, they will ring the care homes, they'll collate all that information, document it all down, and it just makes the whole process much easier when we then pick up the notes and start continuing with the rest of the process. Obviously, it only works. It is a 7-day-a-week service, and we have them from 8:30 in the morning till about 6 o'clock in the evening. But because of resource issues, we have lost our geriatricians on a regular basis over the weekend. We sometimes have them in the morning, sometimes we don't. And during the weekdays, sometimes in the afternoons, we may not have a geriatrician, although we do have them every morning.
Okay, thank you very much. We've got another question from Sharif Hossein. The question is, emergency responses in primary care would often be considered at a 2-hour response as undertaken in OOH. What processes would be required in primary care to ensure a 30-minute response?
So I think the 30-minute response is probably quite important, but maybe we need to change the way we respond. So the 30-minute response could be a callback with a telephone triage, which is what is being done in lots of GP practices in ours in Leicestershire. But there's no reason why we couldn't look at having this as a local thing through NHS 111, and then if needed, using 999 services. One of the things we have certainly seen with the communities call-out services is that the ambulance people, even when they are actually quite happy to leave a person behind at home to be reviewed by the community services, actually lose faith when that response time for somebody coming to see them is 2 hours. That has to be quicker. I know anecdotally, we know lots of times when the ambulance do not have faith in a service that doesn't come there for 2 hours, because they don't necessarily know if the person is going to be fine over the next 2 hours or even longer waiting for this response, so they prefer to bring them into the emergency department. So one of the things we really need to look at is actually ensuring a reliable response that actually follows the whole pathway, and tying in the responders into that. So 111 with our director of needs, with community response teams, with the first responders, emergency care practitioners, paramedics, and district nurses, anything that we have to do it. Instead of deciding it needs to be 2 hours, it probably needs to be as quickly as the person thinks it should be. Because when it isn't, they'll just call an ambulance and come into the hospital. So I think we need to tailor services a lot more, and this is where having prior information and sharing medical records and information between service providers is going to be crucially important, because that allows us to also know about the person and provide a more tailored response. But we have to move away from having arbitrary 2-hour response time simply because that is the best we can do, towards a service that is really looking at what is the outcome we're trying to prevent here, and that's a hospital admission. And when you start equating those into the financial modeling, you will immediately realize how the commissioning needs to be quite different towards specific outcomes.
Okay, thank you very much. We've got another question from Sarah Montgomery. How straightforward is it for you to transfer patients out of the emergency department to bedded rehab if admission is not required? She's also added, just thinking about the crisis care flow chart slide.
Okay, so for a rehab bed, we can't do it from the emergency department. We have to do it, well, we can't, yes and no, because the emergency frailty unit is technically a part of the emergency department, but actually it sits outside. It's about 50 feet away from the back entrance of the majors area. So from there, it's actually very easy for us to do it. So the primary care coordinators, so we have got a very interesting model in the sense the primary care coordinators who work with us, for about 12, 15 of them, none of them are employed by the hospital. They're all employed by the community services, and they have always been employed by the community services, and they've been working with us for about 8 years now. And they have got access to pretty much everything we need in the community. So whether it's a non-bed bearing pathway or it's a bed bearing pathway, it's a social services bed, which is obviously slightly harder to get access to because of paucity of numbers. But with regards to, we have a lot of community hospital beds in this region. We are very lucky and very spoiled as a result of that. But the primary care coordinators do have really good access, and if there is a bed available, we will get the patient there within, if they're seen at 11 o'clock in the morning from an overnight admission, they will be there by 4 o'clock, 5 o'clock in the afternoon. So it's a pretty good service when the bed is available.
Okay, lovely. Thank you very much, Dr. Banerjee. Looks like that's all of the questions at the moment. Like I said before, if you do think of any further questions, Dr. Banerjee's got his email address on the slide there at the moment, or you could email them to frailty@nhselect.org.uk or ecipinfo@nhs.org.uk. Thank you very much for taking the time out to provide us with this presentation, Dr. Banerjee. It's very much appreciated. And also, just a quick reminder that the recording of this webinar will be available on the Acute Frailty Network and the ESIP website shortly. Again, apologies for the technical error earlier on in the webinar. And just to say thank you very much for joining us today. Thank you very much, Dr. Banerjee.
Thank you very much, everybody, for joining in, and thank you for the opportunity. Goodbye.
Goodbye.